be experienced, go and visit people, see how they live their lives. And if you like that, because like you do 4 o'clock ward rounds, man, some people aren't compatible with that.
4:45, yeah.
If it's got a four in it, it's early. I don't know how you have the energy, man.
Yeah, that the fellows these days get a bit of a shock when they start with that one.
Yeah.
They go, "What did I sign up for here?" Welcome to Inside the Shoulder. I'm Kenneth Cutbush, and I'm joined by Dr. Kieran Hirpara, who's up in Rockhampton in Australia. Welcome, Kieran. How are you?
I'm delightful. Thank you very much, Ken. And thank you for inviting me.
So good to see you again. Now, Kieran, you came and did a fellowship with me. Tell me a little bit about that experience of coming doing a fellowship in Australia, where you came from, what that whole scenario was like.
So I did my medical school over in Ireland and then did all of my orthopedic training in Ireland. And towards the end of that, I did a hand fellowship in the UK. And I always wanted to do an overseas fellowship. I needed to learn shoulders because in Ireland it was always shoulder and hand came together. And I applied for various fellowships in Australia. Always wanted to go somewhere, first of all, that spoke English and drove on the same side of the road as the UK and had sun. So that Australia kind of ticked all three of those boxes. Applied to you, and I believed you phoned my reference and then gave me the job, and traveled over for a year after finishing up in the UK. And it was intimidating because you're 24 hours flying away. It's a long trip. And you're bringing all of your stuff on the plane with you. So I had to bring a bicycle because we didn't think we'd have transport when we arrived. Had two young kids with us and arrived into Brisbane and moved into an apartment. One of my wife's cousins, I believe, had just vacated because he was doing a maxillofacial fellowship. And we had a mattress on the floor for a year while we worked with you. Didn't come with furniture. So it was a fantastic experience. Like I came to you having been mostly hand, so I hadn't successfully done much shoulder scoping before I got to you. And within a year, you had me doing crazy stuff. Like came out with arthroscopic lattice, cuff, stabilizations, capsular releases, all within a year. It was a fantastic experience.
It really was fun, wasn't it?
It was so much fun because I was your first, wasn't
You or
I? I was your first
I think
dedicated.
so.
You'd been
Yes,
doing. I
yeah.
was the first of
And
the
then I think
shoulder
Noel
fellows that
came.
you took.
Yeah,
Yeah, Noel came just after me.
yeah, correct. Yes, you were. Yeah, the inaugural shoulder fellowship for me, and it was fantastic. It was really good.
Yeah.
Tell me a little bit about your journey to get into medicine, Kieran. You know, you were telling me your father was in the British Air Force. He
hmm
travelled around.
Yeah. So my dad was originally doing orthopedics back in the day when it was general surgery and orthopedics. They didn't have a separate college. He came from India directly to Ireland, where visas were easier to obtain at the time. Worked there for 6 months, then moved to the UK. And after my sister was born, he felt he wasn't getting enough time at home. He was offered a staff grade position in Glasgow, and he was kind of scared of Glasgow because it was relatively violent. And at that stage, he decided to join the Air Force, and he actually applied to all three. He went to the Army, the Air Force, and the Navy. Got into all three, but chose the Air Force. And worked as a medical officer in the Air Force. So we traveled around with him. And Air Force postings are usually between 6 months and 3 years, and you just get sent everywhere. So we did a stint in Germany for 3 years when I was young, lots of places in the UK, and then did the Middle East for 3 years because the British Air Force loaned him to the Omani Air Force, which is on the end of the peninsula, and he helped set up their medical services. While we were in the Middle East, I had to go to boarding school because I was getting to the stage where I was sitting my A levels and GCSEs and you needed to go in. So I was in boarding school for 2 of the 3 years they were in the Middle East. And I'd always wanted to be a doctor. For some reason, I was fascinated by his bleep. I didn't realize how much I'd hate the bleep in time. When I was a kid, it seemed fascinating that people would get hold of him, get through to him. So I always kind of was leaning towards it was either going to be medicine or computers, and it ended up being medicine. And then as I was going through med school, as I was going through high school, started applying around and found out I could apply to Ireland. Um, and then got into University College Galway, which is on the west coast of Ireland. Did my medical school there, which was a 6-year course, and then had applied back to England to get into training posts and kind of fell into a training post in Ireland for the basic SHO kind of level. Did that 2 years, applied to the orthopedic training scheme, didn't get through for the first time because the competition was quite high, and I was doing my research MD on flexor tendons. So once I had that published and 5 papers published, I was in the running for the orthopedic training scheme and then did orthopedics in Ireland. That was 5 years because the 6th year I did as an out of post training fellowship. Got my English exam in 2013 and then went to the UK for a year to do the orthoplastic hand fellowship in Manchester, which was 6 months plastics, 6 months orthopedics, doing all the stuff you do with hand, and then carried on training to you.
The bleep. What was it about the bleeper? That's the pager you mean that your father
The
had.
pager, yeah. For some reason, it'd go off and he'd look like he was really excited and he'd go and do something and then he'd come back and I'm like, Dad keeps on running around with a pager. I did not know how much I'd hate those things. You learn to get panic attacks when they go off. I remember I knew I'd become a boss the first time I slept through one.
Yeah, right.
That's when you know, like, because your life is run by that pager for like 15 years. And every time it goes off, you immediately have to reply back. And the person who phoned you is never on the other end of the phone. So you sat there waiting at 2 o'clock in the morning to talk to someone about something. And you know that means you're going back in to do something that's going to take you hours. So yeah, my dad warned me that the bleeper was going to be something I hated. And sure enough, I got into medicine and learned to obey the pager.
Tell me, how old were you when you had these memories of your dad with the bleeper?
I was like 6 or
Right.
7. It seemed like it seemed like magic because it was like you're a kid and this was before mobile phones were a thing. So it was like, oh my God, people can get hold of you wherever you are. That's magical. And then it wasn't. We spend our life trying not to answer messages beeping at 2 in the morning.
Yeah, because now we don't have any pages. We've just got
No.
the mobile phone. Yeah.
Yeah. And the funny thing is, when you went to Ireland, they had a load of long range pagers. So if you left the pager in your car when you were driving from Galway to Dublin, which is about a 4-hour drive, you'd pick pages up from all the hospitals you drove past because it wasn't digital, it was an analog thing. So you'd be getting pages all the way across that drive going, well, that's clearly not for me. I'm nowhere near my base hospital. So anyway,
Interesting. Now,
yeah.
boarding school. So your
Yeah.
parents are in Amman.
Amman at the time, yep.
Which boarding school were you in? This is back in the UK, was it?
Back in the UK, I went to Ackworth Boarding School, which is it's a Quaker school, Society of Friends, the people who made the oats that you've seen. And it was out in a little town called Pontefract, which is just outside of Leeds, so about 20 minutes from Leeds. And I was there from like 13 through to 18. So lived on site, was co-ed boarding school, which was kind of what we insisted because we looked at all of them. We'd looked at the Eatons and all of those kind of stuff. And my mum goes, it's probably healthy for you to be around females and not in a male school for the 7 years. So yeah, went to boarding school, lived in site. So I basically moved out of home at around about 13 or 14. Because when I went home at Christmases, I'd have to fly solo. So they had a system, all the Middle Eastern airlines had a system where they walked you through the airports when you were a little kid. So
Wow. And
yeah.
flying home to Amman.
Flying home to Oman, where we lived on a compound and it was anywhere between 38 and 45 degrees.
And your father was where from in India?
So my dad's from Ahmedabad, which is in Gujarat state. So he's from a little town called Ditla, which is a little farming village outside of Ahmedabad.
Wow.
And there's some story, I think we were originally Patels, but some relative of his did some favor for somebody and they got to choose a name, and Hirpara was the name they chose. And effectively, if you see a Hirpara, they're directly related to me in some way,
Is that right?
reportedly.
And your mother?
So my mother was a nurse, worked in Doncaster Royal Infirmary when my dad was registrar there, um, and was Doncaster born and bred, but then travelled the world when we went to join the Air Force.
Yeah, right.
Mm.
So, how hard was it to get into medicine? You're in boarding school, you're away from home. What was that like?
So medicine was pretty competitive. So when we do A levels, you do 3 or 4 A levels, and when I was applying, so Cambridge, which I applied for, was 3 A's and many, many, many hobbies and lots of good references. And most places were kind of 2 A's and a B, which for A levels, considering it was pretty high end stuff because you're only doing 3 subjects, was relatively hard. Now the points translated very, very well to the Irish system where they did 6 or 7 subjects in their final year. So it was a much lower kind of bar for each of the subjects, which is why in Ireland it was a 6 year course for medicine, whereas in England it was a 5 year course because the first year was kind of catching people up to that entering into that second 5 years stage.
Hmm.
So the points translated very well, but it was pretty competitive. I think there were 3 or 4 people in my year who wanted to do medicine, and I don't think any of them got medicine. One got dentistry. And yeah, no one else did medicine. I did go to school with someone who now is the producer for Gogglebox, so she got into TV and various other things, but no one in medicine.
So, med school in Ireland, whereabouts in Ireland was this?
So Galway, which is the west coast of Ireland, so about 4 hours, sorry, west of Dublin.
Yeah, right. Okay.
Mm.
And then orthopedics. Why orthopedics? How did that come about?
So now this is going to sound silly. When I was a kid, I read a book called Neuromancer by William Gibson, which is cyberpunk, and I was fascinated by the idea of robotic limbs. So I wanted to be designing robotic limbs, and that's how I got into the concept of hand surgery. And if you want to do hand surgery, you either do plastics or orthopedics. And I didn't want to do skin cancer because I didn't like the idea of skin cancer. And I kind of liked doing all the like the plating and screwing stuff as opposed to the sitting staring at soft tissue all the time. So that's how I kind of went into hand through orthopedics. So it was always from a very young age, hand kind of lean. Um, and that's then how I got into orthopedic training. And through orthopedic training, it was all hand upper limb kind of lean to the whole thing. And then other people designed robotic limbs and I didn't have to, so it was great.
So, your childhood had a big influence on your eventual professional career.
Yeah. I'm one of those people who basically knew he wanted to be a hand or upper limb surgeon from about the age of 13, 14 onwards.
So, the bleeper as a 6-year-old, and then
Yeah.
the sci-fi book not long
Yep.
after.
And my parents telling
Hilarious.
me, God, don't do medicine all the way through the whole thing. They wanted me to
Really?
go into business. Yep. No, they had no desire for me to do medicine whatsoever, which is weird for an Indian dad. Indian dads are usually big into their kids becoming doctors and engineers.
Yep.
No, he did not want me to do it. Which is weird because my sister then became a psychologist, which is paramedical. Like she's a forensic psychologist in a security hospital in the UK doing like crazy high-end psychology stuff.
Yeah, right.
Mm.
And how competitive was it to do orthopedics in Ireland? How hard was that to get into? In Australia, it's very hard.
When I applied, I think there were something like 18 to 21 candidates for every 6 posts. The year I got on, you had to have either a research MCH or MD submitted and at least 3 papers in big journals. So at least JBJS, JAOS, that kind of stuff.
Yeah, right.
It was pretty intense.
I remember one of the things that struck me about you
Mm.
when we were working together was your amazing ability to write academic papers. You could just, I sort of struggle with them, but you could just sit down there and
Oh,
write them, and I'd look at it and go, man, that's amazing. How good is that? You just had this great gift for writing academic papers.
that was purely just beaten into us because you just sat there writing. Like when I did the presentation circuit, I think I did something like 26 presentations in 4 or 5 years, like international American Hand Society, British Hand Society, all of that kind of stuff. You just ended up slamming through the research, which was a big Irish thing. They were massively into the research as your kind of bar to get in. Whereas the UK had been moving more towards a kind of OSCE, good guy, kind of doing that kind of stuff. The research wasn't that much of a lean to it, whereas Ireland was always really strong academically. And then all of the Irish guys were doing international fellowships in like Mayo Clinic, HSS in New York. That was the kind of the bar that they were setting for fellowships and stuff. So it was always very academic, and it still is. I mean, Hannah Mullet's still pouring out stuff. Ruth Delaney's pouring out stuff. They're still very academic in Ireland, which is weird because it's like it's the size and population of New Zealand, so they don't have the same population density as the UK to produce stuff, but they still produce amazing amounts of stuff.
Now, how has that academic influence um, gone for you later going down the track? I think you were telling me that you're actually doing a
Mm,
new research project now. Tell me a little
mm.
bit about that.
So w- it was much easier when I started in private. Once you're in private, you have control of your stuff and you can start to set up the same kind of the idea that you had, where you have all of your patients getting scored, all of them being followed up carefully, and you can really control the data collection kind of side. So I'd been when I started it up, we'd always been taking scores of people before and afterwards. And I was noticing a lot of the time with shoulders that they were coming back with carpal tunnel syndrome, on the nerve symptoms, that kind of stuff. And I'd had a discussion somewhere where people were there going, "Oh no, that's separate. That's not related to the shoulder at all." I'm like, "No, it's a shoulder. People are getting this." Um, and then I looked it up as you do. The immediate thing is you go to PubMed and find out if anyone's described it to defend yourself, because literature's great for defense. And there was nothing. So we started trawling through our patients prospectively to collect and find out how many of them are getting carpal tunnel syndrome. We're coming to we've got about 2 more months for the year data collection to go. And then I have colleagues in town who want to join CISA, so we're going to get it all ready for them to present at CISA and get in.
Yeah, I certainly see carpal tunnel syndrome after shoulder
Mm.
surgery. What I see is people who obviously have a predisposition towards carpal tunnel syndrome,
Mm-hmm.
and with the shoulder surgery, they get swelling. That swelling goes with
Yep.
gravity down to the hand, underneath the
Mm.
skin through the lymphatics and the subcutaneous tissues,
Mm-hmm.
and it swells their hand, and that then just is enough just to push them over and give them the carpal
Yep.
tunnel, which normally settles down pretty
Mm-hmm.
quickly.
Yeah, but you'll have some people really, really bothered by it. And the shoulder, like a shoulder's a sore joint to operate on. I tell them it's going to be awful for about 6 weeks. And it is.
Can be,
Genuinely, it's about 6 weeks before they can get a good night's sleep again.
yeah.
Um, but some of them just come back and they find it really, really bothersome. And it's quite spectacular just how severe their carpal tunnel syndrome can get after shoulder surgery. Now, as you right say, it does settle. Occasionally, an injection once or twice a year, I have to release one.
Yep.
But a lot of the time it settles, but it's just one of those things that I've started telling people about now. That, the recliner chair for sleeping in after the operation, ice packs, moving over to heat packs once the ice packs start bothering you, all that kind of stuff.
Yeah, I had that conversation with someone yesterday about a recliner chair because they were asking me
Yeah.
how to sleep at night time and asked me meds and medications
Hmm.
and uh, and I just had to say my experience is most of the medications don't work particularly well,
Hmm.
and often the best thing is a TV recliner chair where you're actually sitting up
Yep.
because the gravity pulls the ball of the
Hmm.
humerus away from the shoulder blade and
Hmm.
decompresses it. I think is what happens and often helps them sleep.
The other big thing is it stops them rolling on their shoulder when they're sleeping.
Yeah,
Because I
right.
find a lot of people are saying it's fine, but as soon as they roll over, they wake up. And if you're in a recliner chair, you're not rolling because of that 45 degrees. It really, really helps them. And I tell them that beforehand when they're really sore beforehand, like, just get used to the recliner chair because it's going to be your friend for like 3 months.
Um, talking about carpal tunnel, one of the things that struck me is just the sling. Who would think that you'd have issues with people wearing a sling, but that does.
Hmm.
I'm sure you've seen it. The electron
Hmm.
bursitis,
Yep.
the ulnar nerve irritation that people get too.
Yep.
We talked about carpal tunnel. I'm not sure that's not usually from the sling. And the other thing is wrist pain, de Quervain's tenosynovitis or something. And
Yep.
it's really interesting having to manage the little issues that come up. They all get better and they can be managed and so
Hmm.
on. But I would never have thought going down this pathway that a sling would be troublesome in that way. And because we're always thinking about the surgery and making sure people understand what the risks of surgery are so they're well
Hmm.
informed. But who would have thought that slings cause problems as well?
What I must admit is I've been leaning more and more towards saying, look, the sling is when you're out and about to stop stupid things happening. The reaching out to grab something falling off a chair. If you're in your house, you're sat down, there's no kids running around, there's no dogs to trip over, you can lose the sling just for those moments. But once you're up and out, make sure you put it back on for safety's reason. Just like you do with the capsular releases, they're now losing that sling within about a week. I say have it while the block's on, have it when you're out and about so people don't grab your shoulder but try to lean off of it. And I must admit, I'm probably leaning more towards doing it because they're miserable when they come back. They come back and you say, okay, you can lose the sling today. And every single one has said, thank God.
Yeah.
It's amazingly debilitating. A friend of mine was doing a research study when the Wii Wiggle board came out, the thing you danced on for the Nintendo Wii,
Hmm.
which was basically a pressure sensor, which was good for kind of testing proprioception and stuff. And it significantly affects your ability to balance. And putting people on the sling, like, really increases your risk of falling over. It's amazing how much your arms swinging around helps with your gait and balance that you don't estimate,
Yeah.
really.
Yeah. I agree. I must say that I'm pretty particular about the sling, and I'll tell
Mm.
people they have to wear it full time, and I'm really, really serious about that. And then, there will be occasions where I do what you're doing is let them come out of the sling at home. But
I kind of play it by ear. I tell them all they should, but because all of my shoulder patients come back for a wound check with my nurse next door at a week and 2 weeks, and if they're really finding life miserable in the sling, I'll start to say, okay, you can maybe, because I'd rather them wear it occasionally than wear it not at all. And my worry is if they're really hating it that much, they'll just ignore me and come out of it.
mm, I think it depends on how you
Yeah.
prepare them beforehand.
I tell them all they're going to be in a sling beforehand, but
Yep.
sometimes people do their own thing.
Yep.
Mm.
So tell me about what excites you about shoulder surgery now, because you're telling me that you're going, you're working doing upper limb surgery, and now you're really
Mhm.
just leaning more into the shoulder surgery, which I understand. What excites you about the shoulder surgery? What is it?
So when I first started, I was doing roughly 50-50 split hand shoulder. The problem about hand is a lot of it is emergency trauma work out of hours. Someone's tried to chop their finger off kind of stuff. And the busier you get, the harder it is to slot that stuff in. So that's a big driver to start off with. Because as you get fuller, it's nicer to have planned stuff so that your lists are kind of organized and sensible and you can give everybody the appropriate amount of time and you're not operating on people at 11 o'clock at night just to fit them in. But as I was going through it, I liked the consistency of shoulders. Like, you do your operation, 85% of people get better, 15% of people possibly need something more. It's relatively stable and solid. And the more shoulders you do, the more enjoyable you find the technique. Like, I changed companies on my anchors a while ago and went to a knotless medial row. Sorry, all suture medial row. And that meant I could increase the amount of sutures I'm putting in. And at the same time, I have a nurse assistant who's been working with me now for 5 years. And I was getting her to retrieve the sutures as we were done, like you taught me to do. Up until that point, I had to retrieve all my own sutures. But as I had a consistent assistant, I was training her along. And the flow for doing a rotator cuff just became really nice. And it was a really satisfying, relaxing part of the operation. And suddenly you've got this thing that you didn't think would be repairable when you start. It comes out nice and easy, repaired, sat down, beautiful. And you're like, that's really pretty. I really like the look of that. And the more you get used to that, the more you're pushing out the bar on it. And you go, like, you'll hear about crazy operations like superior capsular reconstructions, which everyone was really kind of intimidated by when they first came out. And you suddenly go, I can do this, I can do that. And then you do that and you go, that's nice. And the more you do shoulders, the more you understand the anatomy, taking the shoulder apart from the inside through doing a lattier, that teaches you so much of the approach to where everything is. The more satisfying that anatomy is, and you're like, I kind of miss seeing the auxiliary nerve. It's nice, it's there, it's always consistent, and you find it. Um, and it's a much more satisfying kind of process now. Um, and that goes with all the follow up. I'm doing a lot of your stuff with the PACNES clearance beforehand. That protocol I have set up now, where they all get a box of stuff coming in, they all have the standard rehab protocols, and you're really seeing your scores improving very consistently. It's a comfortable place to be. Now you still have to push yourself out on the bar a bit, but once you get comfortable with like cuff, all of that kind of stuff, it's just nice. It's just I'm really enjoying them more than I initially thought I would, because I always thought I'd love doing hand trauma. I like doing little flaps and stuff. That was always fun. But the shoulders became real fun. And that was you, basically.
Yeah, I agree. What I liked when I just decided to um, concentrate on doing shoulders and just do
Mm.
shoulder surgery was that my expertise increased,
Mhm.
and I found that really rewarding. That I felt that I was looking after my patients better, that I could give them more expertise, and they were getting a better version of me
Mhm.
in looking after them as a surgeon. That it was very beneficial to the beneficial to the patients. That I was able to get more consistently better results all the time for them and give them
Mhm.
better guidance as to what their shoulder problem was and how would we go about dealing with it for them, and not necessarily surgical.
Even that familiarity with, as you say, the lead up and the thing, all the stuff you go afterwards, you go, I should have told them that beforehand, but because you weren't doing the volume, you didn't know how often it came up, like the carpal tunnel thing. The more you do, the more you can prepare them and go, this is going to happen. Like now I have, for each operation I have my standard consent, which is this is the operation side and all that kind of stuff. And then I have a separate piece of paper, which is this is the complications and expectations of your surgery. This is what will happen. And they sign that as part of the consent and they keep that, bring that home while they're waiting for the operation. Because they never really retain what they talk with you. And the amount of time people come back and go, oh, I didn't realize you'd said that. So now they all go home with a consent that they've signed saying this is exactly what's going to happen. And it just really helps set them up for that process.
Kieran, what was it like? Because you're now working in Rockhampton in Queensland and Australia, and
Hmm.
you grew up traveling around Europe with your father, Oman
Hmm.
and doing boarding school, and then to Ireland, and then
Hmm.
here for fellowship. Why Australia? And how was that? What was that like getting a position in Australia and setting up in well, northern Queensland?
Well, so the plan was always to go back to Ireland to job. Um, I had I had applied to a job in the UK when I was doing fellowship there. I hadn't really tried it. It was more of I should practice at interviews at this stage, so try. But the plan was always to go back to Ireland. And around the time I was doing my fellowship, Ireland was going through a massive recession and they put a hire freeze on all of the hiring of new posts. So the posts I had lined up to go back to were like, well, we're on hold. We can't really go. And the one I was looking at going at was with a guy called Derek Bennett in Castlebar, which is kind of Midland Ireland, which was a town around about a bit smaller than Rockhampton without an airport and lots of rain and cold. So while I was on fellowship with yourself, I was waiting for jobs to come up, waiting for jobs to come up, no sign coming up. And I was like, well, I kind of need to work. And Australia's a really nice place to work. It's sunny. You have airports everywhere. I can have a swimming pool. It's nice. So I applied for the job up in Rockhampton through the public hospital. Because when you come over, you have to do, as an ING, you have to do a bit of working in an area of need, go through your training to get equivalency, do the Australian exam, which was not a fun process, I must admit. And then you're allowed to work. So it was always going to go and do your regional stint, see what happens back home, all that kind of stuff. And realistically, because it wasn't just moving around with the Air Force in Ireland, the training scheme, similar to like you make the Australian guys do, you're moving every year to different jobs as well. So I lived in Dublin, Waterford, Castlebar, Letterkenny. I was all over Ireland, moving every 6 months to every year, and that was tiring. And when we first flew up to Rockhampton, I brought the wife over to it and she looked at it and she's like, I don't want to live here. It's very brown because it was in the middle of the summer season and everything had burned. So I drove her out to Yeppoon, which is a little town about 20 minutes outside of Rockhampton, which is a seaside town. And it is gorgeous, in fairness. It's clear blue sea as soon as you're cresting over the hill getting into Yeppoon. And she's like, okay, this I could do. So we moved to Yeppoon, started up in Rockhampton Base Hospital, where I was doing all the upper limb stuff. Effectively, I've been pure upper limb, apart from when I was in the base hospital doing hip and hip fractures and stuff. Since I moved up in 2016, um, she was like, "Oh, I could do this," and because she'd been moving so much, because the kids had been moving so much, and because by that stage I'd been 2 or 3 years by the time I got the exam in Rockhampton, we're just like, this is us now. There's no need to move again. So that's how we got started up here. And I started up in the Mater Hospital here in Rockhampton. And in fairness, when guys start off in private practice, they get a list every 4 weeks on a Saturday afternoon because they haven't proven themselves yet. There's other guys already there. But when I started up here, I got an all-day list within 3 months of starting. Within 6 months of starting, I had 2 lists a week, and the whole system just evolved really nicely here, so that our setup is nice and smooth. My wife is my practice manager. She knows exactly how all of my business is working. I have my assistant nurse. I have a hand therapist on site. We have a little closed unit of care that's really nicely controlled, and I don't want the concept of trying to start that all over again anywhere else. So we're really happy here. It's a nice town to work in.
And how do the kids go with school?
So that's the scary thing. Yesterday, my son finished school.
Wow.
He is now officially a bloke. He's moving into a house in Yeppoon, like today. Um, they were good, like because they'd moved in loads of different schools all the way around. Every time I moved, they moved. They had been everywhere. And when we moved here, the school ages were different. So my daughter, who had been in school, was back out of school and then started school again. But they've been in the same school now for a while, and they found the education good. Like they're enjoying the time. My daughter's really educational. She's pretty smart, and she's consistently doing really well, which I'll never tell her to her face. And my son is sick of school and is really glad it's over and now wants to become an electrician, which is probably a sensible move.
Not a bad career in Australia.
Yeah, it's a good employment over here. So he's looking to try and start his apprenticeship pretty soon and carry on working that way.
Yeah, right. So they went to school
Mm.
in Rockhampton.
Yeah. So
Yeah,
they
right.
went to the Rockhampton Grammar School. When we first came up to Yeppoon, they started up in their kind of primary school out in
Mhm.
Yeppoon. But we moved them to the grammar school, which is a pretty good school in town, and they kind of consistently went there all the way through.
Now, looking back at everything, what advice would you give to someone thinking about doing a career in orthopedics?
It's a tough life. Like getting started and getting through training in orthopedics is a tough life. It's incredibly rewarding. And it's better than it was. Like there've really been efforts to make the grind of getting through orthopedic training significantly less grindy. Um, and that is a good thing. I don't think how I trained and probably how you trained, where they destroyed you to get you through, and you came out a haggard person at the end of it. I don't know if that was necessarily right. Um, so now it's completely different to when I trained, but it is a tough life because there's never a moment where you haven't got something kind of large hanging around that you need to sort out. You know what I mean? Be it clinic lists, blah, 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 patients that are having issues, that kind of stuff. There's always people depending on you. And you have to like that kind of environment. It is a tough one to have that kind of pressure on you. And it's very rewarding. It is incredibly rewarding. But I don't think it's for everybody. And you have to decide before you commit to it because it's a long process to realize at the end you don't enjoy it. And I've had people who do that. I've had people who go through orthopedic training. And there was one guy who was 4 months before his exit exam decided he didn't like it and went out to become a medical entrepreneur. It's the guy who invented the tightrope, Brian Thorns. He was an Irish trainee. And 6 months before his exit exam, he quit orthopedics. And that's a long time in to decide you're not wanting to do it. Especially here, because here you make your guys wait a little bit to get on the scheme. They kind of have to do the rounds. And they put in quite a few years to try and get on. And if you do that and then find out you don't like it once you're in it, that's not ideal. That being said, it is genuinely, you are making a difference to people. Sometimes it doesn't feel like it. Don't get me wrong. You'll have days where people don't seem happy that they've had their operations. They eventually do, but not when they come back to you at 6 weeks. But you do really make a difference to people, and it comes through. And like my daughter's now got a job, and she's bumping into patients that I treated 4 or 5 years ago that remember her when she used to come in and sit on the desk and are going, your dad operates on me, everything's going great. And this 15-year-old girl's like, that's weird. I can't believe you remember me from when I was 12. It's a great career, but it's a tough one.
Yeah, I've got to say, Kieran, I loved the training. I loved every moment of it. It was just
Mm,
just the best thing ever. But I
mm,
guess people's, everyone's experience is different. And
Hmm.
you're right. I think what I guess for the fellowship, what I look for is someone who's got passion for doing shoulder
Mm.
surgery, and that has always gone well. If I see someone come through with the applications, because we're getting applications most days, but
Mm.
I'll see one come through, and there's clear passion for wanting to be a shoulder
Mhm.
surgeon or learn shoulder surgery, and I've never regretted giving one of those guys a job, woman or man. You know, we've had a lot of female orthopedic surgeons through as fellows and male, and that's the key thing for me, that
Mm.
someone's got passion and it all goes well.
Yeah, and that's the thing. If you really love it, it's a great career, and it's not for everybody. There are people who don't love it. You find the occasional person who seems like they feel is what they should do rather than it's what they want to do, and if they love it, it goes really well.
Yep.
Like I couldn't imagine doing anything else. For me, it was the only job I could do. When I think of the other stuff, no. Um, but again, I'd really coach people to say, really check if it's what you want to do. Be experienced, go and visit people, see how they live their lives, and
Yep.
if you like that, because like you do 4 o'clock ward rounds, man. Some people aren't compatible with that.
4:45. Yeah.
If it's got a four in it, it's early. I don't know how you have the energy, man.
Yeah, that the fellows these days get a bit of a shock when they start with that one.
Yeah.
They go, "What did I sign up for here?"
Yes. Like that's an early morning.
Yeah, it's a good way, and then finish early, get
Mm.
home to the family, get home to my daughter in
Yeah.
the afternoon. So that's a really important thing to me. So I've just shifted my whole day earlier, and I love it. It just works so well. So I get to do what I want to do, and my daughter gets to see her dad. So it's pretty cool.
I must admit, when I heard you were doing 4:45, I was like, that's mental. And then I heard you were getting home early, and I'm like, that's possibly the most sensible thing I've ever heard.
Yeah, look, gives me the school she's at currently. I can't. It's more difficult to go and pick her up, but certainly last year I was
Mm.
going out and picking her up in the afternoon, so it was pretty cool. Yeah, Dad's come to pick me up,
Love it.
and so again, it's about passion. That's something that's really important
Hmm.
to me, and my work's really important to me. So I think you just make it work. That's why I've always looked at it, and you know, you'd be surprised how many patients like a 5 a.m. appointment because there's no
Mm.
traffic. They get in, it's done, everything's organized, and they can then go about their day. And particularly if they've got something that they need, that they're wanting to be, because they're only ever the urgent appointments
Mm.
that we have to get people in, and they like being able to get in to see me and get things sorted.
When I started privately, there was a period where I was running out of space in the week and I started doing Saturday clinics, and patients loved having out of hours access. They really enjoyed it.
Yeah, I haven't done the weekends yet.
Mm.
So, Kieran, thank you so much for joining me on this podcast, or this episode of Inside the Shoulder.
Thank you very much for having me, Ken. It's good to see you again, man.
Really good to see you. Thanks so much for listening. And if you enjoyed this conversation we had, please consider following us on your favorite podcast platform, whether it be Apple or Spotify or YouTube, and consider subscribing to Kenneth Cupler's YouTube channel. Thank you for listening.